going to say a few words about the vaccines, the drugs that are used to treat COVID, and just at the end, I'm going to mention variants. So first, how COVID works. So COVID is a virus, like a cold virus, the same style of virus as a cold virus, and it enters our nose or mouth and gets into our lungs, and deep down into the lungs, it enters the cells that line our lungs. And this is a little drawing of the virus. It attaches itself onto the cells, and then it puts the information it has inside it inside our cells, and then our own cells copy this information and make more virus particles and then shed them, which means that if we then come in contact with somebody and we're breathing or coughing near them, then more virus particles will spread. So what happens when the virus actually gets inside? So if you look really deeply into the lungs, this is how we get oxygen from our environment and into our lungs. There's an alveolus, which is like a little airbag, and all around it goes the little blood vessel, and oxygen comes in through into the alveolus, goes into our red cells, and carbon dioxide goes out. So this is a normal alveolus. When we've got a COVID infection, there's lots of these virus particles floating around, but you can also see that fluid starts to accumulate. And this is true for any infection that we get in our lungs. We will get a little bit of fluid accumulating, and that will be from inflammation, essentially. And for those of you who've had a chest crisis, having that fluid there and having the infection there is also something that increases sickling, and the sickling can start in the lungs, and that would be a chest crisis. But what happens with COVID is that this fluid completely fills up, and that's partly because our own immune system is overreacting to the COVID, and we start to completely fill our lungs with fluid, and that's why people have difficulty breathing. So what are the risks of infection? Well, when COVID first came along, those of us who look after people with sickle cell disease got extremely worried about our patient group, because we know that they're already prone to infections. And the reason for this is because the spleen, which is an organ that lies under your ribs, on the left-hand side, essentially stops working in sickle cell. Usually even by the age of 3, people have a spleen that either isn't there or just doesn't work. And that's why people with sickle cell disease are recommended to take daily penicillin, and that's why they have to take all the vaccines. And that's because the spleen is really important in fighting bacterial infections. Now, obviously, we know that COVID isn't a bacteria, it's a virus, but we also know from, for example, infections with flu, that people with sickle cell are more likely to go into a chest crisis if they get any type of pneumonia, which I've tried to show on the picture before. So we were extremely worried about this patient group. Now, we've been able to collect a lot of data over the past year and a half, and a lot of it has been very encouraging. The risk of you're not more at risk of getting an infection, but once you have it, the risk of having a severe infection is not necessarily far worse than the general population. But certainly from the data that we have collected, so in the UK, for example, we've collected data of over 700 patients who have all sorts of inherited anemias, sickle cell, thalassemia, and other rare anemias, who've had COVID since January 2020. And there's a few important things that I've written here. So if you have hemoglobin SC, which a lot of people consider to be a milder form of sickle cell, well, actually that doesn't protect you from having COVID or having a severe COVID or dying from COVID. So that's my first message, is that having SC, you should consider yourself at risk as if you had SS. Now, what's very reassuring is that children do not tend to get severe infections. So in the same as the general population, children with sickle cell disease are not more likely to get severe infections. If people are admitted to hospital and they need intensive care, and about 5 out of every 100 patients with sickle cell who has COVID ends up in intensive care, then the risk of death is very high. So once you get to intensive care, the risk of death is 70%, 7 out of 10. But also we know that plenty of people with sickle cell disease have gotten COVID and have recovered at home. So as we do our clinics, we're speaking to patients, people that we didn't even know had COVID, we're finding out later that they had COVID and they were fine and they recovered at home. And the other thing that's been interesting is the realization that actually the risk factors for having severe COVID if you have sickle cell, are pretty much the same as the general population. So that means the older you are, the more risk you have, the higher your BMI, so the higher your weight compared to your height, the higher your blood pressure, and the presence of diabetes. So a lot of people want to know about mortality. And I've put this picture of a thorn because that's an extremely thorny issue. And essentially, you have to look at statistics, and it's extremely difficult to look at statistics. The reason for this is that there's lots of different ways that these studies have been done. And even if you're looking at mortality in the general population, and you look through different sources, you don't always get the same information. However, if we use one of the most trusted sources, the Johns Hopkins University source, and we look at case fatality rate, which is the ratio between confirmed deaths and confirmed cases, then we get this measure, we get this kind of measurement, and we can get this for all over the world. So I have, using that graph, I've just selected a few countries that I thought we might have people from today. So we've got the world overall. The case fatality rate is essentially 2%. So for every 100 people who catch COVID, 2 of them will die. We've got Italy 2.8%, UK 1.79%, Spain 1.75%, France 1.66%, United States 1.6%, and Ireland 1.37%. If you want to see for your own country, then please go to see this Johns Hopkins University, and you can find that case fatality rate. But essentially, as you can see, it's roughly about 2%. So a lot of people ask, are you more likely to die of COVID-19 if you have sickle cell disease than if you don't have sickle cell disease? And the answer is it's really, really hard to say, because when you look at all the publications that are in the literature, the scientific literature, it really depends on how large the study was and what time period did it cover. Where was the study done? Was it just in one hospital? Did they do this in a lot of different hospitals? Who did the study? What kind of data did they use? How did they collect the data? So you'll see some studies that the data is lots of anonymous data, like from huge databases of hospitalizations, and other studies will be lots of very few patients, but lots and lots of detail about each patient. It will depend on how patients were treated. So if you're comparing things at the beginning of the pandemic when we didn't know what the treatments were compared to what we know now, then obviously the mortality is going to be very different. How did they analyze it? Where was it published? So some publications will be better than others. So some journals will have publications that will be more trustworthy than others. So I hope you can see that it's not an easy question to answer. And some of the studies say, no, you're not more likely to die of COVID if you've got sickle cell disease than if you don't. And some will say, yes, you are a little bit, or you are a lot more likely to die. At the end of the day, I'm not sure it really matters, because nobody who lives with sickle cell disease is a statistic. So whether you know that the case fatality rate of COVID is 2% with or without sickle cell disease, or 4% if you've got sickle cell and 2% if you don't, does it really matter? At the end of the day, you're one individual, and you're either going to catch it or you're not, and you're either going to die or you're not. So it's really important that we try and I think it's important that we try and move away from these exact, trying to find these exact numbers. It's important that we understand the basic principles that I've told you a bit earlier. And it's important that we all look after each other. But when you're making your own decisions about what you're going to do and how you're going to act with respect to, vaccination or mixing with people and all of that, knowing these exact details, I think is not extremely important. But I'm very happy to discuss this, and I'm glad there's a Q&A after this. One thing I did was I looked at the National Hemoglobinopathy Register. So we're in the UK, where we have about 15,000 individuals who are registered. And just to put it to you in context, so these are the number of people who've got sickle cell disease by age group. So here we've got 0 to 4, and at the end here we've got 70 to 74 and 75, and then this is the number of individuals. So if we look at everybody who's an adult, because we've said that children don't get severe sickle cell, don't get severe COVID, we've got in our registry 6,600 patients. And so even if we assume that sickle cell disease doesn't give you an extra risk of death, and the case fatality rate is 2%, then that would be 132 people who would die of COVID if every single adult with sickle cell got infected in the UK. And again, I'm a very visual person. I I'm not very good at looking at numbers. I try and put it in a context. That would be basically 3 busloads of people who've died of COVID. And I think those are the kinds of things to try and remember, that even if we don't have the exact additional risk from sickle cell, just the general risk of death from COVID is actually high enough to be a concern to all of us. What about the vaccines? So just a little reminder about what vaccines do. Vaccines are an injection of a little bit of a virus, so a little protein that is taken to look exactly like the protein that's in the virus. And once this protein, or the thing that makes the protein, is injected in your body, you make antibodies. And these antibodies will then recognize, if you get infected by a virus, will recognize that virus and will kind of highlight it to your immune system so that you can eat it and get rid of it, and it doesn't infect you. So it doesn't go into your cells and causes your cells to make loads and loads of the virus. So again, I'm talking about the UK, but we've got 3 vaccines that we can use in the UK. We've got AstraZeneca, Pfizer, and Moderna. And the general principles, again, that I want to talk about today are that the vaccines are safe. Now, a lot of you will have heard about AstraZeneca and the risk of clots. And there have been some really tragic deaths of people who were very healthy people who got an AstraZeneca vaccine and who died of a blood clot as a complication of the vaccine. And as a result, it was decided that we should not give AstraZeneca for people under 40 years of age. Now, up until that decision was made, plenty of people did get AstraZeneca under 40 years of age, and plenty of people were fine. It's an extremely rare complication. But especially if we follow this rule, the vaccines generally are very safe and they're very effective. Now, I stand here as somebody who is a proof that you can still catch and spread COVID if you've had your 2 vaccines. So having your vaccines doesn't prevent you from catching COVID. However, if you've had your 2 vaccines, you're far, far less likely to need hospital admission, and you're far less likely to die. So if we compare people who at the moment are coming into hospital and are dying of COVID, then 94% of them haven't had their vaccine or haven't had their 2 vaccines, certainly. So it massively protects you from severe disease that requires hospitalization and death. Certainly in the UK, and I can't speak about other countries, we are talking about 3rd doses or boosters. The difference between a 3rd dose and a booster: a 3rd dose is a full other dose of the vaccine, the way you've had your 1st dose and your 2nd dose, and the booster is a smaller dose. And we've also have evidence that if you receive your booster with a different vaccine than you had for your 1st one and your 2nd one, then that's just as good. And the reason for that is because the vaccines are all a little bit different. It means that your body will make antibodies against slightly different bits of the protein, which is probably advantageous. What about the medications we use to treat severe COVID? So 18 months on, what have we learned? So this is thanks to the scientific community really working extremely well together across the world to do very, very rapid observations and putting all the data together. But we now know that if people are admitted to hospital and admitted to intensive care, then having dexamethasone, which is a steroid, makes a difference in saving lives. And the other drug that also helps is tocilizumab, which is a monoclonal antibody against something called interleukin-6. Now, both of these are to do with dampening your immune response. And remember at the beginning, I was showing you that one of the problems with COVID is that it's the people's immune reactions to it that fills up the lungs with fluid, and that's why they can't breathe. So these are just sort of general methods that will stop the inflammation. What's a monoclonal antibody? Monoclonal antibody is an antibody like the ones that we make as humans, except it's made in a lab. And all of them are exactly the same. So as humans, if you get any type of virus, your body will make lots of different types of antibodies against it. Whereas a monoclonal antibody, they all look exactly the same. And interleukin-6 is a messenger in our body that causes more inflammation. And of course, all of these things are there for a good reason. Interleukin-6 is there to help us when we have an infection, and helps our body to have a fever and to all the things we have, like a stuffed nose, all of those things, because in the vast majority of infections that's the right reaction to have. But with COVID, that goes completely out of kilter. Another drug that's really proven helpful is called remdesivir, and that's an antiviral drug. So that actually prevents the virus from dividing. Now, one of the things that we thought would be really good, and this was something that was done in the UK by NHS Blood and Transplant, so the same people who organized blood transfusions, was they noticed that some individuals who'd had COVID made lots and lots of antibodies. So they took those people and they took their plasma. So they took all the antibodies that these people made naturally, and they gave it to people who were in intensive care as a sort of way of trying to fight the virus. And it's a very good idea, and it's something that works for lots of other conditions. So it's, for example, one of the ways that, it's very similar to one of the ways in which we prevent transmission of hepatitis B. Certainly from somebody, like from a mother to a child, but the trial showed that this actually didn't make a difference in saving lives. And then more recently, it's just been announced a few days ago that actually there's a new COVID-19 treatment, which is called Ronapreve, which is 2 monoclonal antibodies against the COVID virus itself, that we're allowed to use now in the UK. For people who've got severe COVID and who are admitted to hospital and who have problems with their immune system. And that specifically includes people with sickle cell disease, which is really good news. And then before I finish, I just wanted to say a few words about variants so that people could sort of put that in context, because we do hear variants talked about. Now, this is again another picture of the protein, of the virus. And so the virus essentially is a little bit of information to tell your cells how to copy it. And then it's got this sort of envelope around it. And then it's got these spikes that are called the spike protein. And in the bit of information coding, so the RNA sequence, there's a little bit of that information can be changed. Basically, it's called a mutation. And you can see that the mutations that arise in that spike protein area mean that in the normal virus, before there's any variants, the antibodies will recognize that virus and can get rid of it. And that includes the antibodies we should be making from the vaccine. But when you've got a mutation, those same antibodies no longer recognize it. So it's a way that the virus has to try to hide from our immune system. Okay, so for example, why have I got COVID even though I had the 2 vaccines? Maybe there's a mutation in the virus that means that the antibodies I made no longer don't actually recognize the difference in the spike protein in the virus that's infected me. It's actually more likely to be because I had my vaccines in December and March, and therefore my antibody levels are probably just quite low now. But that's the explanation for variants and why we're so concerned about variants, because the more they change, the more they mutate, the more they get, they no longer recognized by our current strategies, our current vaccines. That's all I wanted to say. I just had one last little thing, because when people have sickle cell disease and they've got a fever, we're all thinking at the moment about COVID. And if you call, certainly in the UK, we have a number that you can call for medical advice. That's not the ambulance. It's just sort of medical advice when there's not an emergency. Because sickle cell disease is still something that's quite rare over the whole population, and because, as you've all been talking about, there's a lot of misconceptions about it, the advice will often be that if you think you've got COVID, you've got a cough and a fever, stay home, don't go anywhere. They do recommend that you get a COVID PCR test, but they tell you not to come to hospital or come to the doctor. But staying home with a fever is actually not safe for people with sickle cell disease. Okay, and that's because if you've got a cough and a fever, it could be due to something else. And that's because of what I said earlier about the spleen and the risk of bacterial infections. Our concern is that if you stay home and you delay contact with your medical team, then that could be dangerous. And certainly early on in the pandemic, we had in the UK a very sad case of somebody who died, not of COVID, but of a bacterial infection because they didn't come to the hospital with a fever. Or I don't mean come to the hospital, I just mean contact your medical team the way you normally would, whether that's through your general practitioner or that's through your hematology team. That will depend on where you live. So please keep that in mind, that fevers are not all COVID at the moment, and don't forget that you may need antibiotics. Okay, thank you very much.